Welcome to this explainer on the golden sequence of pre-hospital trauma care. Look, if you're operating in a crisis context, whether that's on a UN peacekeeping mission, a NATO deployment, or doing humanitarian aid work, chaos is basically your baseline. So how do you bring order to that chaos? Well, you do it by relying on a universal operational language. Today, we're breaking down the definitive guide to pre-hospital trauma care. We're going to give you the tactical vocabulary and the framework you absolutely need to approach a high-stakes trauma scene step by step. Let's decode the language of survival. Here is our roadmap for today. We're going to cover scene safety, the primary assessment, the famous XABCDE protocol, the secondary assessment, and finally, the physical exam in history. All right, let's jump right into Section 1, Scene Safety and the Initial Evaluation. The absolute golden rule of emergency response is incredibly simple. You cannot help a victim if you become one yourself. Step 1 is ensuring scene security. You're checking for structural instability, ongoing threats, or any hostile action. Step 2 is biosafety. Especially in international missions or tactical environments, throwing on your personal protective equipment and clearing environmental hazards are absolute, non-negotiable protocols before you ever even think about making physical contact with a patient. Moving on to Section 2, the primary assessment, which is quite literally a matter of life and death. In this primary assessment phase, every single second dictates survival. Your mindset has to be rapid and cyclical. Identify, treat, reassess. You are actively hunting for what will kill the patient first. And the exact moment you find it, you treat it. You do not wait. Alongside this, your secondary goals are to evaluate instability, apply restriction of cervical motion to protect that spine, and make a rapid transport or case-fac decision. It's a highly dynamic, action-oriented phase where multi-agency coordination really begins to take shape. Which brings us to Section 3, the XABCDE protocol and the mnemonic methods we use to execute it under pressure. This universal acronym is the ultimate mental anchor for emergency responders all over the world. X is for hemorrhage, A for airway, B for breathing, C for circulation, D for neurological, and E for exposure. By working strictly in this exact order, you guarantee that you're addressing the most immediate lethal threats first. It completely eliminates hesitation and unifies your team's operational language. And this right here is what that global operational language looks like in practice. On the left, we have the XABCDE protocol, standardized by PHTLS and ATLS, which is heavily used in civilian and humanitarian trauma. But on the right, you'll see the MARCH protocol. That's the standard for TCCC and NATO operations. So if you're deploying in tactical or military contexts, MARCH is your operational vocabulary. But notice the overlap here. Both protocols strictly mandate addressing massive bleeding before anything else. It's the exact same life-saving logic, just adapted to fit different mission contexts. Let's start with the absolute most critical piece, X, for exsanguinating hemorrhage. We are talking about severe, massive external bleeding. You have to control this immediately. You're using tourniquets, hemostatic agents to pack wounds, or heavy compressive dressings. Listen, in a combat or severe crisis zone, if you fail to stop blood loss right here at Step 1, nothing else in the algorithm matters. The timeline just ends. Okay, so once that massive bleeding is fully contained, we move right to A for airway. You have to ensure the patient has an open patent airway. This might require manual opening techniques, using suction to clear out obstructions, or applying oxygen via a non-rebreather mask or a nasopharyngeal airway. And crucially, this has to be done simultaneously with initial cervical motion restriction. You secure the airway, but you always protect the cervical spine. Next up is B for breathing. Now keep in mind, just having an open airway does not guarantee the patient is breathing effectively. You have to physically inspect the chest. Are both sides rising symmetrically? Interventions here might include applying positive pressure ventilation if their breathing is inadequate, or utilizing a valve dressing to seal an open pneumothorax, which you probably know as a sucking chest wound. Moving right along to C, which stands for circulation. We've already stopped the external bleeding, but internal bleeding, that is a silent killer. We assess this using the HPP method, checking hemorrhage, skin, pulse, and perfusion. You are hunting for signs of internal shock by physically examining the chest, abdomen, pelvis, and limbs. Those are the major cavities where a human body can hide massive amounts of blood completely out of sight. Then we hit D for neurological dysfunction. This is where you perform a rapid check of their baseline brain function. You examine the pupils to see if they're reactive and equal, and you evaluate their level of consciousness. Applying the Glasgow Coma Scale gives you a standardized numerical sit-rep. And that's huge because it allows you to instantly and clearly communicate the patient's neurological status over the radio to your evacuation team or your incoming CaseVac flight. The final step of the primary assessment is E for exposure. You need to fully expose the victim to locate any hidden injuries, but there is a massive caveat here. You must strictly prevent hypothermia. A cold trauma patient actually loses the ability to clot blood, which rapidly accelerates the trauma triad of death. So the rule is, expose them to assess and then immediately cover them up and insulate them. All right, that takes us into Section 4, the secondary assessment, where we transition into detailed clinical investigation. So with the immediate, life-threatening issues finally managed, your mindset has to shift. You're moving from rapid intervention to a much more detailed clinical investigation. There's a really powerful operational philosophy here that essentially translates to see, don't just look. Feel, don't just touch. High-level care requires deep sensory focus. You are actively engaging with the patient's body, noticing the subtle details that indicate underlying trauma. You're not just blindly following a checklist anymore. This investigation means getting incredibly granular with their vital signs. For level of consciousness, we use the AVDI scale to see if they are alert, responding to voice, responding to pain, or unresponsive. We check their breathing for rate and effort. We assess the radial pulse for both rate and regularity. We measure capillary refill time, and we thoroughly evaluate the skin for temperature, color, and moisture. Taken together, all these metrics paint an undeniable picture of the patient's stability right before transport. Finally, we arrive at Section 5, the physical exam in history, which is all about gathering context. Communication itself is actually a crucial intervention. You must gather the medical history using the sample mnemonic, interviewing the conscious victim, their family, or local bystanders. You're mapping out signs and symptoms, allergies, medications, past history, last oral intake, and events leading up to the injury. In a multinational crisis, whether you're interacting with local populations or allied forces, your ability to extract this intelligence quickly is absolutely vital. As you're gearing up for transport, you'll conduct a very detailed head-to-toe physical sweep, inspecting everything from the head all the way down to the extremities. This is also the perfect time to integrate complementary technology. You're monitoring oxygen saturation with oximetry, attaching an ECG for cardiac rhythms, checking capillary glycemia for blood sugar, and applying specific clinical scales to continuously monitor that patient en route to a higher echelon of care. So we've unpacked the golden sequence today, from scene safety all the way through the primary and secondary assessments. I want to leave you with one final provocative question. When seconds count, is your protocol automatic? Because in the absolute chaos of a trauma scene, you will not rise to the occasion. You are going to default to your level of training. You need to internalize these steps. Make them your operational language. Thank you so much for joining me on this explainer, and please stay prepared out there.